Hi everyone, my name is Rashida and I'm going to be presenting on the topic of residential structure racism and prevalence of chronic disease, health conditions. Just a little introduction. The study residential structure racism and prevalence of chronic health conditions investigates how structural racism measured through historical housing policies like redlining impacts the prevalence of chronic diseases in urban areas. It emphasizes the effect of discriminatory housing practices on health disparities across racial groups. The introduction also highlights significant correlations between areas historically designed or designated for minorities and higher chronic disease rates, setting a stage for detailed exploration on how redlining has contributed to these ongoing health disparities. The study objectives aimed at investigating the impact of residential structural racism on prevalence of chronic health conditions, specifically chronic kidney disease, diabetes, and hypertension within the Durham County, North Carolina. Also utilizing public data and electronic health records. The research quantifies the association between indicators of structural racism and the incidences of chronic diseases across different neighborhoods. It also, the other objective is to provide insights into how deeply rooted racial disparities in residential areas correlate with health conditions and outcomes of the communities, highlighting the significance of social determinants in the public health. So the methodology that was used, the methodology of the study utilized cross-sectional design, examining the link between residential segregation and occurrence of certain chronic conditions. The researchers focused on a range of health outcomes and considered a variety of demographic and socioeconomic factors to ensure a comprehensive analysis. The approach combines spatial data analysis with structural methods to evaluate the degree of residential racial segregation in various geographic areas and in its association with health disparities. The method also allowed for exploration of complex interactions between race, location, and health outcomes, providing insights into the structural elements of racism and its impact on public health. Data was collected by utilizing data sources from the National Center of Health Statistics and the U.S. Census. For the data collection, the researchers accessed the 2014-2018 public use macro data sample from African American community surveyed for demographic data. They combined this with data from the 500 cities project, which provides small area estimates for chronic disease risk factors and outcomes. These resources allowed them to conduct a cross-sectional study analyzing the relationship between residential racial segregation and the prevalence of chronic disease conditions, including disease, hypertension, diabetes, and obesity. The data was analyzed. The data analyzed included multivariable logistic regression to assess the relationship between structural racism and chronic disease. The regression controlled the various factors, including socioeconomic status, health behaviors, and demographic variables. The outcome of the variables were prevalence of chronic conditions such as hypertension, diabetes, and obesity. Interaction terms were also considered to examine the potential modifying effects of socioeconomic status on the association between structural racism and health outcomes. Results identified significant associations between residential structural racism and various chronic conditions, including hypertension, asthma, and obesity. The findings revealed that Black populations living in this area with higher levels of residential segregation and structural racism had significantly higher prevalence rates of these conditions compared to those in less segregated areas. The statistical analysis confirmed that after controlling for socioeconomic and demographic factors, the structural racism measured through incidences in incidences such as segregation was a significant predictor for increased disease and prevalence. Such highlights the profound impact of long-term racial inequalities on the community health outcomes. Some of the ethical aspects of the study on structural racism and prevalence of chronic conditions focused on the adherence of standards safeguarding participants' privacy and confidentiality. The research deployed data that was de-identified, ensuring that personal information cannot be traced back to individuals. The use of such data often does not require informed consent as there is minimal risk for harm to participants due to the lack of identifiable information. Moreover, the study protocols would have been reviewed and approved by an institution review board or equivalent ethical review committee to ensure compliance to ethical guidelines. This scrutiny ensures that ethical integrity of the study by confirming that research objectives justify the use of data and that the methods and analysis are conducted responsibly and respectfully. Stakeholders, the stakeholders in this study involved diverse range of entities and individuals who have a vested interest in the research outcomes. These can encompass community members who are directly affected by the health conditions under investigation, healthcare providers who diagnose and treat these conditions, public health officials tasked with addressing and managing chronic conditions at the population level, and policymakers who utilize the findings to inform, develop, and health policies. Additionally, academic researchers and institutions have also a stake in furthering education and understanding of the health implications of structural racism. The engagement and cooperation of these stakeholders are crucial to the successful implementation of the study findings into practical, impactful health interventions and policies. And some of the lessons I learned throughout the study in the study examining the relationship between structural racism and prevalence of chronic conditions. Lessons learned might encompass the complex interplay of socioeconomic factors and health conditions. Researchers may conclude that addressing structural inequalities is essential to improving public health. They may also recognize that the need for community-based interventions that acknowledge and target the roots of racial disparities. Additionally, the study might reveal the importance of collecting robust, racially disaggregated data to inform policy changes. It could also highlight the importance of interdisciplinary collaboration involving stakeholders from various sectors and to tackle systematic issues effectively. The study might also emphasize the role of public health professionals in advocating for policy changes that address social determinants of health. These lessons could also guide researchers and action plans aiming to mitigate the impacts of structural racial racism on health. And that concludes my presentation. I think the article and the study was well developed, well presented. Thank you for listening.